Thank you. So our lecture is going to be about bracket prescriptions, Roth versus MBT. Now, just a quick disclaimer. I don't have any financial interest in either Roth or MBT, and I'm not saying that Roth or MBT are better than the other. It's just my clinical practice and theoretical background that shows which one's best and where would it be better and what are the differences between them. So when you go to shop for brackets in the local stores, you're going to search the material. Are they going to be metal, ceramic, or resin brackets? Then you're going to go for the type of bracket. Is it a regular bracket? Is it a self-ligating bracket or other tip edge or other type of brackets? Then you're going to go for prescription. There's so many prescriptions out there like Andrews, Alexander, Ricketts, Roth, MBT, and Damon, and so many others. But the most common two are Roth and MBT. And whichever store you're going to go in, the first thing they're going to ask you is it Roth or is it MBT that you're looking for? And you stay stunned and you don't know which one's which. I hope this lecture is going to clarify where you would use Roth brackets and where you would use MBT brackets and what are the indications and limitations of either. Then you're going to go for the brand, whether you like them to be German made or Chinese made or a specific company, a specific design, a specific size of the bracket. You may like them to be rounded. You may like them to be more rhomboidal. That comes down to your preference, whether you like them to have additional features like hooks or vertical slots. And lastly, you select the brackets that you want. I would like to state that the lecture I would be uploading to my YouTube channel. My YouTube channel has a lot of playlists, which one of them is bracket prescription. I've already posted 4 videos till now, and this one's going to be the 5th. There's a lot of other playlists if you're interested in orthodontics, and they're all free to watch if you're interested in learning. And please feel free to throw some comments and I would answer them surely if you have any questions regarding the topic. So what are the components of a bracket prescription? Well, they're basically 5: tip, torque, in-out, rotation, and slot size. So regarding the tip, what is tip? Well, tip is actually rotating the tooth in a mesiodistal direction. And this is comes about by the angle between the wire and the slot. So if you had a bracket like this one doesn't have any built-in tip. So you can see that the slot is perpendicular to the long axis of the bracket. And if you place it like that on a canine, in which the long axis of the tooth is with the long axis of the bracket, and it looks okay. So what's wrong with this? The minute you insert the wire in, the wire is horizontal, it's going to rotate this bracket around. And once it rotates, look at here, it's going to uprighten the tooth. And so you end up with an upright canine. But we know that for every tooth, there's a specific tip. And we don't want to end up with all the teeth being upright like this. So what do? If we only have these brackets, then we have 2 choices. Either to do bends in the wire, and these are custom designed for every tooth, and this is tedious work. Or you're going to rotate the bracket according to your eye and place it in an angle which is going to come about with the angle of tip that you want. But this is going to be so much difficult because placing the bracket where the long axis is with the long axis of the crown is much easier than tilting it manually like this according to your sight. So that's why they came about with these brackets. And these brackets are the pre-tipped brackets. They have tip included inside the bracket. In the beginning, the bracket was more of a rectangular shape like this, and you would align the long axis of the bracket with the long axis of the crown. And you can see that the tip is very evident here. You have a short wing here and a long one here and here. But this is more difficult to observe and more difficult to place. And that's why a shift happened. And now we use more of a rhomboidal type of brackets, in which these lines here and this one in the middle and this one, they go with the long axis of the crown. And the slot looks as if it's horizontal because the wings are of equal size. But actually, they're not horizontal. The slot is not perpendicular to the long axis. This is the amount of tip. So these are the more recent brackets or the pre-adjusted brackets. They're not very recent, I mean 10 years or so. They've been around for maybe 50 years or so. But these are the pre-tipped brackets. And they can come of a variety of tip, from 0 or 4 degrees of tip or 8 degrees of tip. You've got from 0 to 8 degrees. So what? What if I put some degrees of tip inside the bracket? What's that going to do? How it works is that the wire is going to exert force upward here and downward here. And since this force is, this is the length of the vector here. And if you multiply the force by the distance here, you get the momentum. And this is the momentum that's going to turn the tooth around. So what are the factors that affect the amount of tip expression? Well, first of which is the arch wire stiffness. This depends on the material of the wire and the size of the wire. Because the force, we said that the amount of momentum depends on the length here and the amount of force. If you use a wire material that's stiffer, it's going to generate more force. So if you use, for example, stainless steel, it generates more force than TMA, which generates in turn more force than NiTi. And so that's one factor. And the other factor is the size of the wire. The heavier the gauge of the wire, the more it's going to exert force. But there's another factor here. If you have a heavy gauge wire like this one, it's not going to allow the tooth to translate through the wire. If you have lower gauge wires like these, the bracket can slide through the wire. And this is important when you're trying to correct tip, that you allow the wire to slide through. What about the bracket width? Well, since the amount of momentum is the bracket width multiplied by the force, the wider the bracket, the more the momentum. So if you have a wide bracket, you have more momentum. So you have more tipping. And if you have narrower brackets, you have less momentum. So you have less tipping. So that's something to consider. So if you want to tip a tooth, probably can change that bracket to a wider bracket because it's going to generate more momentum. What about the bracket? So generally, most of the brackets are about 4 millimeters wide, and this is the amount of momentum that's going to be generated. If you use smaller brackets, then they're going to generate less momentum, which is going to be just advantageous in some times and less in others. What about the slot size? Should we use 18 or 22? This angle between the wire and the slot is not that much different if it was a 22 slot or an 18 slot. Here we've got a play of 0.2%, and here we've got a play of 1.6%. So we've got about 1.5 degree of play between the 18 slot and the 22 slot. That's not a good amount of play. So in general, when you're talking about tip, whether you use 18 brackets or 22 brackets, it doesn't make that much difference. What does make a difference is that when you use 22 slot, you can put heavier gauge wires. That's why when heavier gauge wires are placed, they apply more force. So you get more momentum when you're using 22 slots. The other thing is that when you use 22 slots, you have more free space between the wire and the slot. So you get more sliding. And this sliding also helps the tipping. But the slot itself is not of any importance. So in summary, the stiffness, if you're going to do a tipping, you need a stiff arch wire and a wide bracket. The stiff arch wire to generate the force and the wide bracket for the distance, the length of the arm. And for the, you need a 22 slot. The slot is 22 in dimension, and an undersized wire just to allow for the less friction so that they can slide through. Okay, so when you're doing leveling and you place a wire like this, and sometimes you place it and it goes inside, and as you notice, the canine is tilted and it needs to be uprightened by distally moving the roots. What you're hoping for is that you rotate this so that the root moves backward. But what actually happens is that the root doesn't move a lot backwards because it's inside the bone. What happens more is that the crown moves more mesially than the canine root moves distally. And this is going to be some loss of anchorage for you. And this doesn't only stop here. What happens is as the bracket of the canine moves forward and it's binded to the arch wire, it's going to pull even the molars forward. And this is going to cause a lot of loss of anchorage. So when you have a lot of tip on the canine, this is going to pull the canine crown mesially, and it's even going to pull the posterior teeth mesially. And this is going to create a loss of anchorage. Concentrate with me that this loss of anchorage happens even if you have round wires and not rectangular wires. This even happens when you're just starting treatment with very low gauge wires. So this is a very early phenomena that happens in orthodontics. When you have a lot of tip, it affects the anchorage loss from day one. And this doesn't only involve the canines. This involves all the other teeth, canines and centrals and the lateral incisors. The more tip you have, the more you want the roots to move distally, the more the crowns are going to move mesially, and the more you get loss of anchorage very early in treatment. And this is very important to remember because we're going to come back to that when it comes to prescriptions. So non-extraction cases, little tip is much preferable. Or if you must have a lot of tip, then what we do is we use lace backs. And by that, we bring a ligature wire and ligate it on the 4 and 3, whether it's a non-extraction case or an extraction case, and that's to limit the amount of mesial movement of the canine. Or alternatively, you can early on start with a TAD and just ligate a ligature wire to the canine to prevent this mesial movement of the crown of the canine. What about torque? Now, torque for beginners is the angle between the arch wire cross-section and the cross-section of the slot here. It is designed to move the root and the crown of the tooth labially and lingually. Now, torque could be negative if the root is going buccally, or it could be positive if the root is going lingually. And the torque is generally nowadays placed in the base, in which the face of the bracket is generally the same. But what's different is this base here. You see this angle between the base of the wire, the bracket, and the slot. The more the angle, the more the torque. So this is 0 torque, and this one is up to 17 degrees of torque. And why do they do that? And that's to push the roots lingually and labially. But it's important to remember that the position of the brackets on the teeth affects the torque expression greatly. If you position the bracket high up, you would notice that the torque is almost 0. This one's horizontal. Whereas lower here, you would notice that you've got a significant amount of torque. So if you place the wire up the bracket much higher here, you get almost 0 torque. If you position them lower, you get a much higher torque. So it's a much more positive torque, pushing the roots more lingually. So you have to concentrate about that and put that into consideration. So how does torque work inside a bracket? Well, it's the same thing. You want to generate a momentum, and to generate a momentum, you need the amount of force, and you need the length of the arm of the vector. This arm of vector is no more than, in a 22 slot, no more than 0.8 millimeters from these 2 points of contact. So it's 0.8 millimeters and not like 4 millimeters when we were talking about tip. So it's 5 times less the amount of distance. So to generate the same momentum as we did with tip, we need 5 times more force. And that's why torque is so difficult to accomplish, because torque requires a lot more force than tip because of the absence of the vector here. So since it's a very small place where it works, it really needs a good amount of force. And this high amount of force can easily distort the wire or distort the bracket. And if the brackets or the wires get distorted, then it doesn't work. That's why a lot of us know, orthodontists know, that when it comes to torque and finishing in the end stages, if you're using cheap brackets, what happens is that these slots, they just open up like this. They open up. Why they open up is because of the extreme amount of force. So you really need good brackets if you want to torque them. You need good brackets, larger size of brackets, so that the wings are large enough to withstand the amount of force, from a reputable company that uses good medical grade stainless steel. So that's why torque is so important here. And what are the factors that play? The same thing. Arch wire stiffness, which provides the force. And for torque, it's not easy to apply that heavy amount of force with lower stiffness or flexible wires. We generally need more stiffer wires. We need the fitness of the bracket, the wire inside the slot. If the wire is not fitting inside the slot, there will be play. A 1925 wire generally provides about 10 degrees of play. And this means that the tooth can move freely, buccally and lingually, within this 10 degrees and without any consequences, because there's a play here. And that's why it's always desirable to try to fill in the slot as much as possible. This play doesn't even work just in one direction, it plays in both directions. The tooth can move buccally or it can move lingually with the same wire in place. So actually the tooth, this bracket allows the tooth to move 10 degrees labially and 10 degrees lingually. And hence you can see that there's not much control over torque, although I'm using 1925 stainless steel wires. So the arch wire size should be as much as possible to fit. A full fitting wire would be desirable for torque expression. Now, this isn't clinically applicable in most cases, but it is desirable as much as possible. And for the slot depth, it should accommodate the whole wire, because if you're using cheaper brackets, they don't come here with sharp ends. They come at a more rounded ends. And these more rounded ends means that when you put the 1925 or 2125 wire, it doesn't go exactly all the way in. So it comes out a little bit from here. And if the wire comes out, it's not going to actually hold on to both sides from here and here and torque the bracket. So a good bracket quality would have more of a butt joint here, a very sharp angle here, or sorry, not sharp, a right angle here, but very sharp right angle, not a rounded one. In addition to that, the quality of the stainless steel, the design of the bracket, this should be very good stainless steel so that it prevents the bracket from just twisting and the opening up of the wings. Another thing is the slot size. Unlike with tip, slot size matters a lot in torque. If you use 18 slot brackets like here, They differ from 22 slot brackets like here. If you notice, there's about 10 to 13 degrees difference. So if you use 18 slot brackets and you put 1622 wires, you've got about 7 degrees of play. And 1825 would only generate about 1.2 degrees of play. But wait a minute, this is an 1825 wire in an 18 slot bracket. Shouldn't that be fitting exactly? No, it doesn't fit exactly, because most of the manufacturers will make 1825 wires just slightly smaller than 1825 and make the 18 slot just slightly larger so that it can accommodate the wire without a lot of friction. So there's a little amount of play, but this is 10 degrees higher when you're using 22 slot. And for the 1622, it's about 20 degrees. If you give and take labially and lingually, that's about 40 degrees. So it's practically a 1622 wire in a 22 slot is, well, it's almost round. It doesn't provide a lot of torque at all. So here comes overcorrection. If you're going to use torque, then you got to think about overcorrection, because you've got a lot of play that even in the best wires is going to be a significant amount of play. You cannot just place your brackets on the laterals and centrals and hope for the best that these are going to align beautifully. They won't align beautifully. This is a case which came to me. This tooth is more proclined. This one's more upright. Look what happened. Look at that. This is more proclined. This is more upright. So as you progress with wires and you place wires and you try to uprighten the teeth and you correct the torque, we've finished the leveling stage, but look at that. We still have this more upright, and we still have a little bit of torque. I mean, the labial proclination of the left central. And there's nothing you can do about this using your 1925 stainless steel, because your 1925 stainless steel provides 10 degrees of play. You're either going to go for a full engagement of 21.5 by 25 slot, or you're going to use another mean like changing the bracket to a higher torque or putting an auxiliary so that it aids you with torque management. Another example is this one, in which these laterals were in crossbite condition. And as you push them outward out of crossbite, they become more labially proclined. Now, if you just ligate them to the wire, it's not going to be enough to pull the roots out of the labially so that you can correct this crossbite, the proclination that has happened. What you really need is to have more exaggerated amount of torque. So what we commonly do as orthodontists is flip the bracket around, and it gets a minus 10 degrees of torque opposing to the plus 10 degrees, which is 20 degrees. And this 20 degrees is so much, it's so much over exaggerating. In real life, minus 10 degrees means that the root should come out of the bone by 10 degrees. But in real life, this doesn't happen. Your root never comes out of the bone 10 degrees. It doesn't come out of the bone. Why? And that's because of the play. So here always we over exaggerate. We put more amount of torque than we actually need, because the play is going to soften that out. So in summary, a stiff full-sized arch wire is required, and an 18 slot would be better. Even if it's for just one bracket, which I need to torque, I can just put an 18 slot for one bracket, not all of them. You need good brackets, and you need to overcorrect. The third component is an in-out. Now, some brackets have an in-out depth of about 0.5 millimeters, like the upper lateral incisors and the lower incisors, and the upper second premolar and the MBT system only. And that's why you look at these brackets, you can see that the slot base is very close to the base. The lateral incisors, they're rather thick. The canines and premolars a little bit thicker, not much thicker. And the fives are very thick as well. Fourth thing is rotation. Now, as you retract canines, what you get is mesiopalatal rotation of the premolars and distopalatal rotation of the canines. So these rotate as they move mesially and distally. To counteract that, you can place rotational bends, and I mean rotational design in the brackets, in which you would put one wing much longer than the other wing. Not much, maybe 0.5 millimeter would do it. And you take these brackets and you place them on the patient's mouth, and these are going to be counter rotation brackets. And what happens is that they're going to rotate the bracket in the other way around. They'll rotate the tooth so that they counteract the effect of the rotation. So it's not going to rotate as much. But in real life, you don't find these very often. I have found premolar anti-rotation 2 degrees brackets, but canines are very rarely found. But there are some, like Alexander's, they do those, but not in most of the prescriptions. But you do find them very commonly in molar tubes. Molar tubes, you have an offset of 5 or 10 degrees, and this is very commonly found in molar tubes, but not that much in brackets. What about the bracket slot? 18 or 20, it's part of the prescription. 18 slots are very small, and so that you can put an arch wire that fully engages the wire, and fully engages the slot. And as it engages the slot, it's going to torque very well, especially with stainless steel wires. You can use them on selected teeth just to torque them, especially in non-extraction cases where sliding is not important. But with the larger 22 bracket slots, this is going to allow more sliding, and it allows the use of larger, stiffer wires, or you can put full gauge, less stiff wires like night tie wires, which are full gauged. It's more useful in extraction cases and selected teeth that you want to slide because it allows for sliding. However, as I showed you before, it doesn't affect that much the tip control, the tip expression, but it affects greatly the torque expression. So with that said, we've finished the components of the prescription. As you noticed, that the prescription is a lot of information to perceive and put in your mind. A lot of people are going to say, I don't care, as long as I've got a good technique of work, I don't need to use which prescription. Many have argued that any prescription can work as long as the technique is right. This is true, but prescription is a tool. I can take it to my advantage and it makes my life easier, the treatment time shorter, or I can make it against me, and it's only going to make things worse for me. So we take a little history about prescriptions and how they evolved. In the old days, before straight wire appliances, they used heavier forces and thinner wires. And so they got this roller coaster effect, in which you get this bowing of the dental arches. And as especially in extraction cases, when you have a mesially inclined canine, and then you retract this canine backwards, and you end up with a distally inclined canine. The distally inclined canines, as you see after retraction, is going to cause the wire to drop down in the upper arch and up in the lower arch, and this is going to create extrusion of the incisors and deepening of the bite. And this is going to be very difficult to treat and difficult to retain because of the vertical component. And that's why all the efforts are to try to rotate these teeth back and keep the wire as straight as possible and the occlusal plane as straight as possible. So came in Andrews in 1972, and he done his famous article on 122 non-orthodontic patients, and he studied their tip, and he found that all the teeth are mesially inclined. All of them have a positive amount of tip. All of them have mesial. The second, as you can see, all of them are pointing forward from the centrals to the molars. But this is especially true for the upper lateral and the upper canine. Another thing, when he studied torque, he noticed that only the upper centrals and laterals have a positive torque. The mandibular incisors have a slightly negative torque, and this increases with negativity as you go back. The more you go back in the arch, the more you get more negative torque, to be the most in the lower 7. However, the torque of the buccal segment of the upper arch is very comparable, ranging from -7 to -12. So he came up with his plan of the original straight wire appliance. He placed more tip on the canine and the incisors in the upper and lower arch. And this was designed so that it's going to rotate these teeth and correct their tip, because as he viewed, this was a tip problem. So the teeth are tipping distally. He made them tip more mesially. And as they're going to tip more mesially, it's going to correct the roller coaster effect. What about torque? Well, he didn't do much about torque. He just left torque as it is. He just made them more even at -7 here and -9, made their numbers more rounded to remember, but nothing else much. Most of his work was about tip. So does that prescription work for everybody? No, it doesn't. When there were 2 other variants. For class 2 patients, he designed upper and lower brackets that have different torque values. The upper incisors would have less torque, so that they're going to be torqued in with the crown lingually, and the lower being more torqued out, so that they have a more positive torque and they're going to be more proclined. The opposite happens with class 3, in which you have an exaggerated proclination of the upper incisors and an exaggerated retrusion of the lower incisors. And this was all done by using fully engaged wires. And as you place the fully engaged wires, they're going to express the torque built into the brackets. So he ended up with 3 sets, one with class 1, which was the traditional, one with class 3, and one with class 2. And once he uses the fully engaged wires, he's going to get the amount of torque which he needed. But came along Roth, and Roth just viewed this as too complicated. 3 sets of brackets and a lot of other things that were in the Alexander system. So he pulled them all into just one system. The one system, what he done is that he also viewed the roller coaster effect. And this was by increasing the tip on the canines even further than what Andrews did. Also, he removed the tip from the posterior teeth, so that the posterior teeth, which Andrews didn't address, Roth addressed them here. So what happened is that Roth generated tip effect on the posterior teeth by making these all 0 instead of they were actually being mesially moved by the Andrews appliance. This one just tilted their teeth distally so that it enhances anchorage, and he increased the anchorage on the tip on the canine. That's to move the canine root backwards and also to straighten out the roller coaster effect. What about the torque? Well, they also increased the amount of torque, and for the central incisors and the canines, and they decreased the amount of torque for the molars. The increase for the incisors and the canines, that was to deal with the counterintuitive effect of the increase in the tip on the canine, which is not something I'm going to discuss today. But why did they make the negative torque even higher on the upper molars? And that's because the molars, the palatal cusps were sticking down, so that the teeth are going to be more buccally positioned, with the palatal cusp moving down and opening the bite. So they just torque that tooth inside so that the palatal cusps don't just stick down. So the summary of a Roth appliance is that it's made out of one set, not like Alexander's. The upper and lower canines have more tip, which is as an overcorrection. The upper anterior teeth have more torque as a sign of overcorrection. The decreased tip in both upper and lower buccal segments enhance anchorage, and the upper molars have less torque, and this was a molar control for the palatal cusps, which sink down. Then came along MBT appliances. They published their first book, Orthodontic Treatment Mechanics and the Pre-Adjusted Appliances in '93, which is a very valuable read. And then they progressed further on. Their major book was Systemized Orthodontic Treatment Mechanics in 2001, where they mainly introduced their MBT system. And as it goes forward, the last version they have done now is MB5 with some modifications to the system. So what they realized is that when you put a lot of tip on the canine bracket, as Roth did, what happened is it creates a significant drain on the anchorage, which I explained earlier in the beginning of the lecture. When you put a lot of tip on the canine bracket, you're trying to rotate the canine crown mesially and the root distally. What happens is that this moves forward and it brings all the posterior teeth forward. And this happens from day one of treatment. It happens with your night eye wires, with your round wires. It doesn't wait until you're into rectangular stainless steel. It happens from day one. The second thing is that it creates a tendency for deepening of the bite as the crown moves like this and then goes inside the heavy slot like this, a very tilted slot. It moves the wire downwards, taking the upper incisors downwards, which is going to create a bit more gummy smile and the deepening of the bite during alignment stage. And the third thing, in non-extraction cases, it brings the canine root very close to the root of the upper four. And that wasn't also desirable as well. So what happened is that when MBT started to address the prescription problem, they recommended tip to be much less than what Roth did. They made it more closer to what Alexander did. And that's by removing about 7 degrees of tip in the upper arch and 8 degrees of tip in the lower arch. And the primary objective of that was that we do not want to lose anchorage very early in treatment. Then how are we going to control the roller coaster effect? And that's by increasing the torque on the interior brackets. The torque here only works when you're later in treatment and you're into full gauge wires, full gauge rectangular wires, which there you'll be more capable of treating and handling the amount of loss of anchorage. And that's why they shifted for the control of the roller coaster effect from the tip to the torque. So that's why they gave a +5 on the central and a +2 on the lateral incisor. For the, and this increase in the amount of proclination or the torque, positive torque given to the upper central and lateral should help in the roller coaster effect so that you don't get that roller coaster effect. Another thing is that they gave a lingual root torque to the lower incisors, and to the lower crown, lingual crown torque to the lower incisors, so that we're going to push them more lingually. And this is going to actually make the patient more of a class 2 type of character. Although the MBT was originally designed for class 2 patients, why would they make the crown of the lower incisor move more lingually? Well, that was basically because it deals with crowded area crowns where the lower incisors are crowded and you don't want them to be flared. And if you're going to use intermaxillary elastics, so that if you're going to use intermaxillary elastics and you're going to flare the lower incisors, this -6 degrees is going to help keep them upright as much as possible. Another thing with canines, in the canines, they gave 3 solutions, one with a positive torque, one with a 0, and one with a negative torque. And they said this is related to the arch form. If you've got a wide arch form, you're going to go with the negative one, which is going to tuck in the canines more lingually. If it's not medium-sized, a 0 would be okay. And if it's a narrow arch form, you're going to go with the plus, the proclination type, which is going to push the root more lingually and the crowns more labially so that they stay within the cancellous bone. What about the posterior segment? Here's a place where most people just don't think about and they don't know. The difference between MBT and Roth brackets are basically very important. What has happened here inside the torque of the posterior segment. In the posterior segment, you'd notice that the premolars went up 5 degrees, and the 6 10 degrees, and the 7 20 degrees. So that instead of the Roth being the regular torque, which was the real torque that was found by Alexander in normal patients, the MBT just makes these teeth more upright. And when he makes these teeth more upright, it's going to help expand the mandible. And this is very useful in class 2 patients. It's useful in scissor bite patients. And it's useful in flattening the curve of Monson. And this is especially true for the 7s, because they noticed that with -30 degrees, as in Roth, the 7s, they just roll in and they go into the lingual so much. So they just made it so much less, by 20 degrees less, so that they just become more upright. And this is very important to consider when you're choosing. So as a summary of MBT, MBT also has one set, although it's very versatile, and that's also not the topic of today. You've got another video on the channel talking about the versatility of MBT and how you can switch the brackets of the MBT. And it has less tip on the upper and lower anterior teeth. The upper anterior teeth are more proclined. The lowers are going to be more retroclined, and it goes for uprightening of the posterior teeth. So that's the goals of the MBT appliance. So to sum that all up, in the upper arch, what you're going to do is in the Roth appliance, the most important bracket is the canine bracket, which pushes the canine tooth more mesially, losing anchorage very early in treatment. Whereas in the MBT system, you've got a lot of positive torque for the central and lateral, which is going to make them more proclined. But when you use heavier gauge wires later on in treatment with the rectangular wires. For the lower arch, you've also got the same canine thing in the Roth appliance, making it lose more anchorage and making the canine move more mesially early in treatment. For the MBT, it's all about torque. It's going to move the lower incisors more lingually and uprighten the molars. And that also only happens when you've got fully engaged wires, and these fully engaged wires are rectangular. So which appliance do I use after all this talk? Well, after all that talk, what you're going to use is either MBT or Roth, I would presume. If you've got critical anchorage, then I wouldn't like to use these canine brackets because of the Roth, because they just lose the anchorage very early. So I would go for MBT. Unless you're using auxiliaries like TADs or headgears, where anchorage doesn't matter. If you've got posterior crossbite and you want and it's a crossbite, you try to stay away from MBT buccal teeth in the lower because they uprighten the molars. You need to actually push these teeth more lingually to correct the crossbite. But if it's a scissor bite, then an MBT would be nice because it uprightens the molars. If you're using class 2 elastics, then MBT would be better because as you retract these teeth backwards, they already are more proclined. They have a lot more positive torque here. So as you retract them, they become more upright. The same thing as you use class 2 elastics, you procline the lower incisors, and the built-in negative torque counteracts this proclination. So this is very good with MBT system. If you're going to use class 3 elastics, then the opposite is true. You do not want the MBT brackets on these upper incisors, which procline them so much. You want the Roth brackets, which have less torque, so that they don't procline that much. And you want the 0 degree torque, lower incisor Roth brackets, so that they don't tip lingually so much. So that's for class 3 elastics. And to sum it all up, I would say as an indication of Roth appliance, I would go for mostly class 3 cases, especially if you've got a retroclined maxillary teeth, which you want to procline, but control their proclination. Or if you're using class 3 elastics, as I described earlier, or if it has posterior crossbite, which I also described earlier. Or if you have a class 1 case where anchorage is not critical, because if anchorage is not critical, then that's no problem. You want to lose the anchorage by your canine brackets, which have a lot of tip. And this is cases where spacing that's treated by loss of anchorage, if you want to move the canine forward to create close anterior spacing, or if you have crowded teeth that are treated by extraction, because if you're treating by extraction and anchorage is not critical, then you want the extra tip in the canines to position the roots more vertical and more appropriately so that you don't end up with distally inclined canines. But Roth doesn't work that well with class 2 cases anyhow. It works better with class 3 cases and class 1 cases where anchorage is not critical. What about MBT brackets in general? Well, MBT brackets are they work better with class 2 cases, especially with upper extractions, where you've got upper extractions and you're retracting. You want the extra torque in the upper centrals and laterals so that they don't fall in lingually inclined. If you're using class 2 elastics, so that the increased torque on the upper and the decreased torque in the lower, they're going to work better. And if you're retracting on TADS, you also want the increased torque on the upper incisors. Class 1 cases where anchorage is critical are also something that you can use MBT brackets. When you've got mild crowding and you've got a class 1 case and you want to just unravel this crowding, probably by widening the arch or interproximal stripping, you do not want the Roth canine bracket. The Roth canine bracket gives you loss of anchorage. So if you've got critical anchorage and you do not want to use TADS or something, you stay away from the canine or the Roth canine bracket. But you should use undersized wires, because if you use full gauge wires, you end up with expressing the torque of the MBT, which converts the class 1 case to a class 2 case by proclining the upper incisors and retroclining the lower incisors, which is something that you don't want. So if it's a class 1 case where anchorage is critical and it's a non-extraction case, you need to use undersized wires so that you don't express the torque of the MBT. You just use the decreased amount of tip of these brackets so that you don't lose the anchorage very early in treatment. And mild class 3 cases can also be treated. The same thing which Alexander done with his class 3 brackets. By using fully gauge-sized brackets, the fully sized wires, you can use the MBT system to procline the upper incisors and retrocline the lower incisors to help in treatment of mild class 3 cases. But you have to use the full-sized wires so that you can express the torque in full. But it doesn't work that well with most of the class 3 cases where the wire gauge isn't fully engaged. So remember that Roth, when you're purchasing Roth brackets, the most important thing to look out for is the K9 tip of the Roth bracket. It's going to lose you anchorage very early in treatment. So you have to watch out for that if it's not desirable. And if you're going to use MBT brackets, then avoid using full-sized wires unless you really need the torque and you need the torque control. If it's a class 1 case, avoid using full-sized wires in an MBT system. Try to go for a lower gauge wires, and these are going to give you the advantage of the decreased tip without the increased proclination of the upper incisors and retroclination of the lower incisors. However, I do have another lecture in which I would mix and make a hybrid system between some Roth brackets and some MBT brackets. If you're interested, you can see that. And I hope you had a nice time watching the webinar. That brings us to the end of the webinar. And thank you for your kind listening.